All right, welcome to this explainer. We are diving straight into decoding some incredibly high-yield endocrine cases today. We're going to use a continuous flow of clinical questions to figure out exactly how to navigate these really complex physiological feedback loops. There's a ton of fascinating ground to cover, so let's just jump right in.
Here's our roadmap for today. We're hitting thyroid diagnostics and therapeutics first, moving right into surgical interventions and oncology, and wrapping up by looking beyond the thyroid at systemic lesions.
So, Section 1, Thyroid Diagnostics and Therapeutics. We are starting right at the biochemical baseline to see how we accurately assess and monitor all that intricate thyroid signaling. Okay, consider this first clinical scenario. You need the absolute most useful and accurate baseline screening tool for a thyroid profile. Which of these markers do you actually trust? You've got T3, T4, TSH, reverse T3, or none of the above.
If you guessed C, TSH, you hit the nail on the head. It is absolutely your best first-line tracker. Why? Well, the anterior pituitary is exquisitely sensitive to even the tiniest changes in free thyroid hormone. Because the relationship between free T4 and TSH is logarithmic, even a minor peripheral variation triggers a massive amplified shift in TSH secretion. Plus, relying on TSH helps you completely sidestep the diagnostic headache caused by transient changes in serum protein binding. Basically, if that TSH value is strictly normal, you can comfortably exclude primary thyroid dysfunction.
All right, follow-up scenario. Say you're actively treating a hypothyroid patient with exogenous levothyroxine. How do you reliably assess if your therapy is actually working? Are you going to check T3, T4, TSH, reverse T3, or thyroglobulin?
This one builds into a really crucial three-step protocol. And once again, the answer is C, TSH. Tracking it is essential. You have to titrate the dose until the TSH normalizes. But here's the kicker. You absolutely have to wait a full 6 to 8 weeks to hit a true biochemical steady state before you retest. If you check peripheral free T4 too soon after a patient takes their pill, you're going to get this transient, totally misleading elevation. You just have to trust the timeline and trust the TSH.
Let's shift gears to hyperthyroidism for a second. If a patient has a palpable nodular goiter and documented biochemical hyperthyroidism, what is your next step to confirm the internal architecture? Look at these options: T3, T4, TSH, reverse T3, or an iodine-131 radioisotope scan.
And the correct answer here is E, the iodine-131 scan. Radioisotope scintigraphy literally maps out the internal functional architecture for us. If you see a single intensely hot nodule, you're dealing with a toxic adenoma, also known as plumber's nodule, and the surrounding normal tissue is suppressed. On the flip side, if you see a really heterogeneous, patchy landscape, that points directly to a toxic multinodular goiter. It perfectly sets these apart from the diffuse whole gland uptake you'd see in something like Graves' disease.
All right, Section 2, Surgical Interventions and Oncology. With diagnostics out of the way, let's talk about managing those toxic goiters and identifying some pretty dangerous malignancies.
Imagine you have a young, 36-year-old, highly symptomatic patient presenting with a toxic multinodular goiter. How do we definitively and safely manage this? Radiotherapy? Radioactive iodine? Just antithyroid drugs? Do we do an immediate total thyroidectomy? Or prep her medically before surgery?
This is absolutely critical. The answer is E. There is a strict resuscitation prerequisite here. You must render the patient strictly euthyroid medically, using antithyroid meds or beta blockers before you ever consider definitive surgery. Operating directly on a thyrotoxic patient without stabilizing them first is strictly contraindicated. Why? Because you risk triggering a fatal intraoperative thyroid storm. Once they're safe, a total thyroidectomy is preferred for a young patient to prevent any long-term recurrence.
But what happens when a previous, less aggressive surgery leaves behind tissue that decides to flare up again? Picture a 39-year-old female coming in with a recurrent mass right over her old neck scar, 2 years after a subtotal thyroidectomy. She's tachycardic. What's the right move now?
The answer here is A, radioactive iodine therapy. Listen, re-exploring a dense, scarred central neck compartment is incredibly dangerous. That dense scar tissue totally obscures normal anatomical planes, which puts the recurrent laryngeal nerves and the parathyroid glands at massive risk. So radioactive iodine ablation is by far the safest, non-invasive way to downregulate that hyperfunctioning recurrent tissue. Pivoting to the oncology side of things now. Which of these physical exam findings should instantly raise your suspicion for an advanced, invasive thyroid cancer? Dyspnea, dysphagia, a hard neck mass with mobile skin, an irregularly hard and fixed neck mass, or a productive cough.
You guessed it, D, an irregularly hard and fixed neck mass. If you feel a mass that is physically anchored to the prevertebral fascia or the deep strap muscles, you're looking at direct tumor infiltration. And here's a huge clinical pearl for you. If the patient has a non-occlusive bovine cough, that is practically pathognomonic for unilateral recurrent laryngeal nerve paralysis from tumor invasion. Oh, and never forget, a solitary nodule in a male patient statistically carries a much higher probability of being malignant.
Okay, so we biopsy a suspicious mass, and the pathologist report comes back. What specific cancer is diagnosed by the presence of pacemamomo bodies? Follicular, papillary, anaplastic, medullary, or lymphoma?
The correct answer is B, papillary carcinoma. Pacemamomo bodies are these round, concentrically calcified structures that actually form from necrotic papillary tips. Finding them is incredibly diagnostic for papillary thyroid carcinoma. I mean, you almost never see them in follicular or medullary variants. You also want to look for classic nuclear features like those optically clear orphan Annie-eye nuclei and distinct longitudinal grooves. Seeing those pretty much locks in your diagnosis.
So you've successfully treated that papillary carcinoma with a total thyroidectomy and ablation. What is the most sensitive marker to make sure the disease hasn't come back? Serum T4, T3, TSH, thyroglobulin, or calcitonin?
It's D, serum thyroglobulin. Because thyroglobulin is produced exclusively by normal thyroid tissue and well-differentiated cancer cells, it should drop to absolute zero after a total thyroidectomy. Any detectable rise is a massive red flag for metastatic recurrence. One quick caveat, though, you always have to measure baseline thyroglobulin antibodies, or TGAB, because those autoantibodies can falsely lower your results. And just to keep things straight, calcitonin is used exclusively for medullary thyroid carcinoma.
All right, finally, Section 3, Beyond the Thyroid, Systemic Lesions. Let's expand our view and look at how endocrine disruptions play out in the adrenal and pituitary systems.
Check out this fascinating clinical mystery. A patient develops generalized hyperpigmentation and headaches after having a bilateral adrenalectomy for Cushing's disease. Which hormone is actually causing this hyperpigmentation? MSH, TSH, prolactin, ACTH, or dopamine?
The culprit is D, ACTH. This is a classic textbook presentation of Nelson syndrome. Here is exactly how that feedback loop works. Removing the adrenal glands surgically totally eliminates cortisol from the blood. No cortisol means no negative feedback on a pre-existing pituitary microadenoma. So that pituitary tumor just starts growing autonomously, which causes the headache, and it floods the body with sky-high levels of ACTH. That excess ACTH then cross-activates the melanocortin-1 receptors on the dermal melanocytes, which is what darkens the skin.
For our last case today, let's talk about a true clinical emergency. Once you biochemically confirm a dangerous pheochromocytoma, which is an adrenal medullary tumor, what is the safest test to physically locate it? Ultrasound, CT with contrast, MRI, an MIBG scan, or radioisotope scan?
This is a critical safety pearl. The correct answer is C, MRI. Why not a CT? Well, standard intravenous CT contrast can actually trigger massive tumor degranulation, throwing the patient into a life-threatening hypertensive crisis. We definitely don't want that. Instead, we safely rely on an abdominal MRI. On a T2-weighted sequence, the pheo lights up intensely bright, the classic light bulb sign, and often shows this necrotic Swiss cheese matrix configuration. It's just a vivid reminder of how powerfully these systems communicate, leaving us to wonder, what other hidden, exquisite physiological signals is the endocrine system broadcasting right now, just waiting for the right scan to be decoded? Keep that in mind next time you're reviewing a lab panel. Thanks for going through these with me today.